Join us this week as we host one of our viewers' favorite shows, Ask Anything. The show focuses on all medical topics affecting those in our viewing audience. Ask Anything tonight on Call with the Prairie Doc.
Welcome to On Call with the Prairie Doc, health information based on science, built on trust. I'm your Prairie Doc host tonight, Dr. Debra Johnston, and we will be hosting one of our viewers' favorite shows, and one of my favorites too, Ask Anything. You may have noticed I'm sporting a new accessory tonight. 'Tis the life of a doctor during the respiratory illness season, and I had a significant exposure recently. Dr. Holm always said, stay healthy out there, people. And tonight, that means making sure that our crew, my patients, our guests, their patients are not going to be exposed by me. This evening, we are joined in the studio by Dr. Samantha Gervais-LeClaire from the Center for Family Medicine in Sioux Falls, South Dakota, and Dr. John McAreavey, a family medicine physician from Prairie Lakes Brown Clinic, Northridge in Watertown, South Dakota. Welcome, and thank you both so much for joining us tonight. Sammy, tell us a little bit about your background and what inspired you to be a primary care doctor.
Yeah, so I'm from a really small town in southwest Minnesota called Prairie, and you know, around our area there's not a lot of primary care doctors that, you know, they'll come, and once they retire it's hard to get docs back. So my primary care doctor, my family practice doc growing up really inspired me to go and be that person that people can rely on in those rural communities. So it's part of the reason, one of the many reasons why I joined medicine and wanted to be a family practice doc.
Fabulous. John, what's your story?
Grew up on a farm in a small community, and got the opportunity when my mom worked actually in a special ed preschool, and got to see the interaction with young kids and how the medicine, the background part, and the science interacted with real human beings, and kind of set me on that path, and kind of started with physical therapy and then actually morphed into being a medicine, being a doctor, and I enjoy the pediatrics, the obstetrics, that whole spectrum of life, and that's kind of where I ended up, I say, falling back into family practice, but I've very much enjoyed it.
Fabulous. It's a great field. Of course, I'm biased.
Absolutely.
So. Before we start our conversation, we invite you, our audience, to submit your questions for tonight's discussion. Viewers can contact us 3 ways. Call 1-888-376-6225, send an email to ask@prairiedoc.org, or ask at our Prairie Doc Facebook page. We will work to answer as many of your questions as possible given the time available. Sometimes we receive more questions than we can cover, and we apologize if we don't get to your question. Your question will remain anonymous and no information is saved. Viewers can leave their name, email, or phone number to be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie, but it's not required to submit a question. The winner will be drawn and announced at the end of the program. And we've had questions come in already, which is always exciting. So it's a good sign that we'll have a great discussion today. So let's get started. We have a question from Facebook on a person who has been having stomach problems for years, and they had an ultrasound on their gallbladder, and that didn't show anything. So they had a HIDA scan that showed the gallbladder only functioned 8%. The surgeon that this person saw didn't sound real optimistic on taking the gallbladder out, helping. What are your thoughts? John?
If only we had a crystal ball, you know, we could give that a shake. And so just because a test is abnormal doesn't mean it's the cause of the pain. And so it's very important as we go through things, we're kind of trying to correlate what is that what does that test indicate, and if it correlates with what their symptoms are, it's a slam dunk and we know what's going on, but oftentimes that's not the case. So I think that's probably a point where you would say, okay, we're going to work through the process of elimination and we're going to make sure we're doing everything else. There are times where we end up saying it's probably reasonable to go back and have another conversation with that surgeon and saying this is probably a realistic thing to try and see if that makes a difference for the patient. So, and that's a lot of times where it's nice to know your surgeons and have that conversation with them in person too, and see how strongly they believe or don't believe in that too.
Sammy, what does the gallbladder do for a person?
Yeah, so the gallbladder is a small little organ that it's kind of this green color that sits underneath your liver on your right side, and it secretes something that the liver makes called bile, and it helps break down some of the fatty foods that we eat. So usually when you're having some gallbladder pain, it's usually after some type of fatty meal that we eat, and it can be causes for needing to come out would be like a obstruction or a blockage of that bile with a stone or something, because those sorts of things can get infected and can get pretty serious pretty fast.
Yeah, but sometimes they just don't squeeze very well, and that can cause problems. But sometimes we see problems after the gallbladder comes out for not having the gallbladder. Yeah. John, what's your experience with that?
Absolutely. Most people, I find that their bodies probably adjust to a certain extent, but certainly processing fatty meals is a common problem. And so sometimes it's a good biofeedback, because pretty soon you learn that you have loose stools and complications if you do eat too greasy a food. So you can joke it's kind of a weight loss product sometimes.
Yeah.
But it isn't always, most people do fine without it, but there is some feedback when you do that.
We always called it the gallbladder diet in my household.
Yeah.
I'm on the gallbladder diet. So.
Yep.
And it did tend to be a pretty healthy diet, but wasn't necessarily a lot of fun.
Yep.
So. All right, we have another question from Facebook. This person has been clenching their jaw at night, and they finally went back to wearing their mouth guard, but now their shoulders have been hurting as well. Can clenching your jaw make your shoulder muscles hurt? John, that's a good PT kind of question.
Well, absolutely. And so I think I would probably focus on a little bit of what's the underlying cause. So if we're clenching, sometimes you can have pathologic TMJ type stuff, but is it stress, is it anxiety, what other pieces are there? And so there's times there's medications that may help with that, but certainly other times, whether it's physical therapy, stress relief, counseling, really it's kind of one of those where you'd have to kind of delve into the situation and see, all right, what's the underlying cause? Because it shouldn't move from the jaw to the shoulders if it was arthritis, and so it tells you there's something else underlying it that probably deserves looking into.
I always like to tell people, it's that old children's rhyme, the knee bone's connected to the hip bones, so everything's connected, but those tight muscles usually don't just come out of the blue. So. This one's from email. There's a lot online lately about increasing your protein, especially for women as you age, specifically in menopause. Is this necessary, and why would it make a difference in your health to add more protein? Sammy.
Yeah, there's, as we age, there's different things that change in our bodies, specifically around menopause. We have kind of a drop in some of our hormones that we have, and the ability to, process different things that we eat, and maybe the ability to, work out and do the things that we used to like doing. So I think eating a fair amount of protein is really important. As long as, around menopause, I think along with eating the proteins is doing strength-based exercises, making sure that we're adding in those routines that incorporate strength, and not necessarily weightlifting, but resistance to help that bone health, not only muscles but bones. So,
John, anything to add?
Yeah, I would agree. As we look at total calories consumed and what's that food pyramid look like, and so certainly we tend to, as we cut back, sometimes we forget about the protein piece of that. And so I think when you say the word diet, most people kind of have a negative connotation about that. But to me, it's how does that balance and how does that work for you? And everyone's very different. So I think it's making sure you're meeting those needs. And there's times we're fortunate we have a couple of dietitians available in our community that sometimes we even have people and work with them. and there's lots of variations in all this. There's been paleo and there's Atkins and there's all these different fads to a certain extent. But I think making sure you're meeting those essential needs. Now you flip it around, and I see it probably more in my younger athletes, but you can overdo protein, and that you can go nuts. And I would say most middle-aged women probably aren't going nuts on protein, but you can, like anything, you can overdo it. So it's trying to find that healthy balance, and there are ways online or with your provider or with the dietitian to kind of say, okay, what is that healthy need? How much protein do you can get very scientific and calculate it, but most of the time it's just kind of common sense too.
And I always want to be careful to make sure that people who maybe have chronic kidney disease recognize that their protein needs and limits are different than everybody else's or other people's. So it's not a one-size-fits-all answer. So here we have another Facebook question. I am in my 50s and female and have been getting targeted ads about weighted vests to help with bones. What would this do to help your health as a woman? Sammy.
Yeah, so we kind of just mentioned as we get older, the estrogen in our body kind of lowers, and that kind of helps promote bone health. So a lot of studies out there are saying that we should incorporate some tension building exercises, whether that be with resistance bands or some subtle weights to try to help with that possible loss of that bone health. So whether you add a few more weights when you're walking a couple times a week, it really does make a difference, I think.
Yeah, I mean, the studies have been very clear that weight-based activity is the most important thing for bone health, and so it's like anything, you can make it as complicated as you want, and so I think a little skeptical. I think some of that is marketing and people making a buck on something that's a fad. But at the end of the day, if that little spend of money helps get you motivated to go exercise a little more or go for a walk, and maybe that's what you need to get to push it. But I don't know is that adding something like that's going to reinvent the wheel. But I think that number of 150 minutes a week of exercise is really important, and that's been pretty consistent across a lot of different studies. And so whatever it takes to get us moving, and again, weight bearing, being on your feet up, doing is important.
I'm always skeptical of people trying to sell me things. I think that's there's a lot of things out there that can look really slick. And you've really got to kind of delve into it to say, all those things you're saying support your product doesn't actually talk about your product. It talks about the theory behind your product, but you're going to be fine just getting out there and walking. Jumping jacks. Do some jumping jacks.
There you go.
That's pretty easy and pretty darn cheap. So. Here's another email question about the fish oil pills. They read that they may not prevent heart attacks after all. John?
Yeah, I mean, I think things kind of go in cycles, and you've probably seen this as well. And that was the end-all and be-all for quite some time. And the practical part of fish oil is that sometimes you get what you pay for. So really cheap fish oil, you feel like you've been eating bad fish and the fishy breath and all that stuff. And the realistic answer is it probably doesn't make as much difference as we once thought it was. I'm not an expert in that area, but that's my understanding, is it's not probably as good as it once was. So I think in general, that Mediterranean diet, the heavy meaty fishes, your avocados, your olive oils, some of those things certainly can make a difference, raising your HDL and some of those things that do bring to the table. But most of us have kind of moved away from a strong recommendation on doing fish oil regularly, I guess.
I can't remember the last time I told someone to take fish oil. I don't take it myself. Yeah. All right. We have an email person who has been having right hip pain off and on for about a year. It mostly hurts when they first get up in the morning, and if they sit for a long time. It doesn't bother with walking. This is a woman in her 50s. What could be causing it, and what can I do to help with the stiffness and the pain? Sammy, you want to suggest some options, some thoughts?
Sure. Well, the first thing I would probably suggest if we haven't been seen for something is to go to your primary care doctor and be initially evaluated for it, because we could try some subtle interventions like stretches or maybe some over-the-counter medications that maybe we haven't thought of in the past. Maybe it's a referral to physical therapy next, because our physical therapy partners really do some magic with our joints, our muscles, because we might not know like whether or not you're sitting at a job in a kind of a certain way, or whether you're using your muscles in a different way that you don't know about. So they can kind of help you adjust that. So those would be like my first interventions for if she hasn't done that first.
Yeah, I mean, it sounds pretty classic for arthritis type stuff. And so movement is medicine. Getting up and moving is a good thing. So particularly if you can work past that morning stiffness. And starting with, depending on health, and working with your provider as far as anti-inflammatories to taking the edge off. I see a lot of people are like, they get afraid to move because I think they're going to make it worse. And yes, I wouldn't go train for a marathon, but getting movement is key. And so therapy can help motivate with that. And sometimes if it's starting to interfere with life, it's keeping us from sleeping, then maybe there's other prescription medications, x-rays, looking into it type stuff. We also look for mechanical symptoms. So if you're locking, if you're catching, if it's giving out, paresthesias, numbness, tingling type stuff, would all be kind of red flags that would put us down a different path looking for other causes.
And it's always worth thinking about possibly an inflammatory condition too with that morning stiffness, but physical therapy is almost always my first answer for everybody. And honestly, it works most of the time. So that would be, go see your doctor and expect a referral to physical therapy. So. All right, this one is an email question. My husband has been shuffling for the past year and having vertigo episodes and is tired a lot. He is approaching 70. Nothing has come back from the cardiologist that indicates heart problems. What could it be? John?
You've got a couple of different things there. Part of it is family history and things, so sometimes people hear shuffling and automatically the brain goes to Parkinsonism or that Parkinsonism type things. What medications is he on? Is this something somebody's creating, or is it a pathologic, organic type process? Older males, sometimes there's other things we go looking for, normal pressure hydrocephalus. I mean, you can go down a lot of different rabbit holes with that one. So I think having a primary doc kind of help you through a couple of those things. It's always good to make sure it wasn't heart, but none of the things mentioned there make me think cardiac-wise. And so I think evaluation, whether it's looking for other processes, and then because if it is Parkinsonism, medications can help. So there's times we end up with our neurology partners involved as well too.
Yep. Lots of different possibilities, and a good thing to have your primary care provider help walk you through that and figure it out. Osteoporosis is a bone disease that occurs when the body loses too much bone, makes too little bone, or both. It can cause fractures and breaks that can lead to dangerous situations. Prairie Doc spoke to family medicine Dr. Leah Prespo, who leads metabolic bone clinics for Avera, to understand more about the condition.
So osteoporosis is a condition that develops that means that your bones are easier to break than those of the average person. Okay, so what we're basically trying to do is help prevent that bone loss that leads to osteoporosis, but also once you're in that category and that bone has gotten to a spot where you're at a higher risk or even a very high risk of breaking things, we have medicines available that we can employ that can even in some cases help build bone so that you have less of a risk of breaking.
Osteoporosis can occur for a number of reasons, some which include diabetes and rheumatoid arthritis. Those who are most at risk are postmenopausal women.
When we're kids and in young adulthood, we're building bone like crazy. And then when you're in your middle age, you're kind of just sort of stabilized. And then when menopause happens, things really start to decline from a bone perspective. So that's one of the big things that puts people at risk.
Fracture risk assessments may be completed on osteoporosis patients. This online screening questionnaire identifies what may increase your risk of getting osteoporosis. The best way to determine if an individual has osteoporosis is to complete a bone study, which is also known as a DEXA scan.
So though when we're doing a bone density study or DEXA scan, we sample certain different parts of the skeleton by taking x-rays of those parts, it is a disease of the entire skeleton, meaning that we just use those certain spots to give us an idea of what's going on everywhere. The most common way to screen for osteoporosis is with that DEXA or bone density test. So we recommend a DEXA scan for every postmenopausal female at the age of 65 or later, but you might get it earlier than that if you have some of those other conditions that predispose to osteoporosis also.
Habits such as excessive smoking and alcohol use can increase your chances of osteoporosis.
The big thing I like to stress with young people who are trying to prevent osteoporosis, other than moderating any kind of smoking or alcohol use, is to make sure you're getting a good amount of calcium and vitamin D through your diet, because those things can help you build bone during that time in your life, childhood, teenage years, 20s.
Ways to help aid and combat the effects of osteoporosis are by ensuring you have the correct intake of calcium, along with doing weight-bearing exercises.
For the general public, as far as osteoporosis is concerned, if you're young, do everything you can to keep that vitamin D and calcium level good. Get that weight-bearing exercise, build your skeleton while you can. If you're in middle age, be thinking about your risk, be thinking about the possibility. If you do break something, talk to your doctor. And if you're getting into that later stage of life in the 60s or older, then definitely be reaching out to your primary doctor and talking about getting a bone density study, or at least doing the FRAX to make sure we know whether you're at high risk or not for osteoporosis.
I think a lot of the questions we had earlier really relate to osteoporosis, so it was really good timing there. So we've got more questions that we get to talk about. So this is fabulous. You guys keep it coming. This one's from Facebook, and this is, I think, something that a lot of us can really relate to. How do I shake this chronic exhaustion that I've picked up during the pandemic? Sammy, what are your thoughts on that?
I think first kind of looking at your day-to-day life and subtle changes that you can make in that. Like what time are you going to bed at night, and what time are you waking up in the morning? Are you getting good quality sleep? Are you having a good sleep environment where it's cool and quiet and there's no blue light like we're all on our phones prior to bed or computers?
Or at 3 o'clock in the morning we get up and check.
Exactly.
Yeah.
So I mean, starting there, but I mean, and then going out from there, is there other things that could be causing it, whether that be, social factors, whether there's a lot, going on at work or at home, other health concerns, after branching out, trying to figure out what might be causing the fatigue.
John, anything to add?
Yeah, I mean, I would agree, trying to rule out and make sure that, and most times you probably have, the thyroids, the anemias, the other medications type stuff, and then it really kind of is getting down to some of the lifestyle pieces. What's the diet like, and you can really go down a lot of different rabbit holes as far as, inflammatory markers and some of those kind of things. And I'd reiterate, sleep is huge. Anxiety, mood, depression is huge. Physical activity, it's hard to beat natural endorphins, whether it's even 10 or 15 minutes of a slow walk, just getting outside. Sunlight, sometimes it's vitamin D. Are we getting enough sunlight? It's one we sometimes forget to check. And so it's tough because it's such a vast open area, and it isn't a one-size-fits-all for everyone.
Absolutely. Fatigue is a really important condition, and it can be caused by just about anything.
Everything.
And I think that there's a lot of issues after the pandemic, a lot of people that are just emotionally exhausted after the pandemic.
Yep.
So. Here's a question from email. Someone who has hypertension, and they're wondering if it's worthwhile to get themselves a blood pressure cuff.
I think blood pressure cuffs are great if they are calibrated to the right settings, because sometimes I'll have patients that will buy them and they're they have the appropriate cuff size, which is also important for readings. But when they bring it, once we bring it into clinic and have it checked, it's a little bit off. So I think that might cause some anxiety at home if it's too high or too low. So if you do purchase a blood pressure cuff, I would recommend bringing it into clinic and just making sure that it runs the same.
What should you be looking for if you're going to buy yourself a blood pressure cuff, John?
Boy, I'm going to play it a little bit ignorant on that. A lot of times I'll refer them to the pharmacy to see if there's one. Most things, sometimes you get what you pay for, sometimes not, so you don't need all the bells and whistles. So in my mind, it's just a standard cuff, and it is just making sure they can help you get the right cuff size for this arm size is the biggest thing. I've had sometimes folks come in and they've got spreadsheets, and it's like I think they have high blood pressure because they're worrying about it too much. So, and there's always the idea of white. I have some people that come in every year and always just white coat, and I'm like, yeah, I'm probably not. I think you have legit high blood pressure. We need to get this treated. And so it is a way to get some patient buy-in and get some. I certainly like to see those ambulatory pressures and see if they validate what we're seeing in the clinic as well.
I always discourage people from using the wrist cuffs. I mean, you really want an arm cuff, and you want to empty your bladder, sit there for a few minutes, have your back supported, feet flat on the ground, arm at about heart level before you take your blood pressure. And that it's important to do it correctly to make sure that cuff is the appropriate size. So it can be really valuable, but you also have to be sure that you're doing it correctly. So, all right, we have another Facebook question. Oh, this is a good one. I recently had a case of shingles. Can I still get the shingles vaccine, and should I get it? Sammy, what do you tell your patients about the shingles vaccine?
I say get it. Yeah, especially if you've had chicken pox before, I think that just knowing people that have gotten shingles in the past, it's very painful, and I think that the shingles vaccine, although it's not easy, the arm hurts, you can have some flu-like symptoms afterwards. I've heard through and through that it's better than getting shingles.
Yeah, I think if I remember correctly, you had about a 40% first chance of shingles, and interesting enough, if you've had shingles, it's about a 40% chance of getting it again. So just because you've had it, you've got about the same odds of getting it again. It isn't worse, but it isn't necessarily less.
And it tends to get worse the older you are. So if you get shingles at 50, or if you get shingles at 75, the 75-year-old is more likely to get the pain that won't go away after shingles than the 50-year-old is.
And the chronic post-herpetic neuralgias, the chronic nerve pains, or those things are uncommon or rare, but they are miserable, and it's really hard for us. We just don't have great treatment. We do our best, but they're tougher to treat. So I think is it usually a 3-month waiting period after you've had an active case of shingles. So you do for
3 months, or even as much as 3 years. I've heard it's a little bit of a.
So I have told folks that you're probably not in a hurry to go get the vaccine. I would give it at least 3 months, but
it's not going to hurt you if you do. But that case of shingles was kind of a booster anyway, which is what the shingles vaccine is. It's a booster to your immune system to say, hey, remember this virus that you got when you were a kid that never really left you? Well, don't forget me. Don't forget me. So, and I have had a lot of complaints from my patients about, you're off my Christmas card list because that shingle shot made me feel rotten.
I warn everyone, the first one is usually fine. I've had 2 that had some of the stuff, but it's about 60% of folks feel like they have the flu for 2 to 3 days. And so I tell people, just know that going in, it's going to happen. It doesn't affect how well it works for you, but just know that, just plan accordingly.
Plan accordingly. And then I tell them, and when I had mine, my arm was a little bit sore when I laid on it on that side. So it doesn't knock everybody out, but it knocks enough people out to warn you about it. And here's someone who called in. Do the effects of anesthesia worsen with increasing age of the patient? That's a good question. John?
Generalities are tough, but I would say yes. I do definitely find my older folks and particularly, I would say north of 70 or 75, and if they already have some memory issues, whether it's minor cognitive deficit or true dementia, those folks do probably get hit harder with that. And so it's probably also dependent a little bit on how long and how much anesthesia as well. So if you're looking at bigger cases, that's probably more of a deterrent as well. So sometimes it's just knowing that it may take days to weeks or even potentially longer to kind of get back to baseline.
And some of them never quite make it all the way back to baseline, especially with those big surgeries, long cases. Anything to add, Sammy?
I don't know. I think you guys hit it on the head.
Here we have a Facebook question. My child seems to have more ear infections in the winter months. What can I do to help prevent them? Sammy, that's a great question.
Especially for this time of year.
Yes, it is.
Yes. So a lot of ear infections we're finding out are viral causes. So, you see the signs up in bathrooms and at your doctor's offices, but really like making sure we're covering our mouths when we're coughing or sneezing, making sure we're really washing our hands, which can be so hard for kids to do, but at least the adults and older kids around them can try to do that to try to limit any spread. As far as like prevention within the ears themselves, there's not a whole lot to do because it's a viral illness, but having those precautions beforehand, you can try your best. It's really hard to do when they're young though, when they're going to daycare and school and stuff, and know that it's fairly normal for kids to get multiple ear infections when they're young.
And multiple respiratory infections. So, anything to add, John?
I mean, as far as a specific prevention, not really. I mean, obviously good health and and we get lots of questions about vitamins.
Breastfeeding.
Absolutely. So breastfeeding is a lot of immune factors that are great. I think was part of it older. If you're talking about for that first year of age, certainly getting them through that first year. If you have a kiddo that's getting north of 2, 3, or 4 and having recurrent infections, then you kind of have to say, okay, is there an underlying something, and is this a kid that we should be maybe visiting with our ENT folks about tubes? Because they can really reinvent, make it better for them. But certainly trying to be healthy is the best you can, and I get lots of questions about multivitamins and things, and for most of us, I don't know is that's going to truly prevent infection unless there is an underlying deficit or need.
Yeah, just know that the more infections they get in daycare as little people, the fewer that they'll see for the first time when they go to kindergarten. So it's tough. And the ear infections do get better as they get older for most kids.
Correct.
So. Here's a question from Facebook. I took cephalexin for 10 days for strep. 3 weeks later, I again tested positive for strep and a sinus infection. Here we are 4 weeks later, and I still feel ill and exhausted. Any advice on how to get some energy back? They're currently on Ceftin. John.
So it kind of starts to dabble a little bit with, are they a strep carrier, and is that actually a true strep test positive? And so this time of the year, we have the benefit now, we have some testing of the nasal swabs we can do. So if somebody really is struggling, I sometimes will do the respiratory panel that gives me 26 different viruses. So it's rhinovirus, it's enterovirus. The vast majority of them I can't treat, and it's kind of an expensive test. So I don't do it for the average person, but if someone really is struggling, sometimes that is a tool that tells us, I'm sorry, your sinus infection is enterovirus and it's going to take 2 weeks. I can spend $1,000 in antibiotics and I probably won't get you better any quicker, to be honest. So it's trying to work through that process. Now, if they have little ones in their home or they have a spouse, maybe they're sharing it in a circle. And so there are times where we have sometimes said, okay, enough's enough, and we've tested other family members to see if someone has it. There's different theories on whether you treat colonization and carriers or not, and I'm not necessarily the expert in that, but sometimes if it is getting frustrated in a circle, that is something to do. In this case, they kind of went from one cephalosporin to a next, and so sometimes do we need more atypical coverage or a different approach on the antibiotics is another thought I guess I would have in that situation.
And did they replace the toothbrush? Did they replace everybody's toothbrush? I mean, there's some of those kinds of things to think about too, and I always do wonder, are we looking at a virus of some kind? That,
Sometimes it's just unfortunate. You have bad luck. And
sometimes you've got that little person who's bringing everything home from daycare. So here is a caller who's asking about neuropathy. Sammy, what do we have to offer neuropathy patients? First off, what is neuropathy?
So neuropathy is, it's a term that we use quite often, but it's kind of a numbness, tingling that people can feel. It can be anywhere in the body, but I see it most of the time in the hands and the feet. Something that people or patients that have diabetes deal with, but can be from a lot of different medical conditions. Some of the better medications that we have are like, if you've heard of like gabapentin and those sorts of medications we prescribe often for neuropathy. Sometimes depending on the disease process, what has been lost kind of is lost, and we try to do what we can. It's a really hard thing to treat, to be honest.
Yeah, I mean, I would agree. The underlying cause is probably the first thing we try to focus on, so preventing the damage that's ongoing. So if diabetes is by far the most common, alcoholism, certainly sometimes it's medication, sometimes it's disc disease, back disease, whatever that might be. There are several of the medications, I would agree, that can help take the edge off. It depends sometimes. A lot of times people say it's this irritating discomfort. It's not pain, it's not like it's 10 out of 10, you can't, but after a while it just starts to really grate and wear on you. So, so there are different classes of meds we can use that are kind of neuromembrane stabilizer type things to try and help take the edge off. It is tough, and I guess my bias as a primary doc is I see a lot of stuff on TV, and most of it drives me nuts because most of it, there is no miracle cure. If it truly is neuropathy, unfortunately it's not going away. How do we help your quality of life, and how do you feel better? Physical therapy, the movement, the neuroflossing guides. I mean, there's lots of things that we can do to help, but unfortunately there isn't that one answer that fits at all. And I guess I encourage folks, I mean, if you got lots of resources and you want to try it, go for it, but there's a whole lot of things out there that take a lot of money that aren't proven and don't really help much.
Yeah.
So I'd be very cautious with a lot of the stuff out there.
If it sounds too good to be true, it probably is. So.
Yeah.
Prairie Doc spoke with the South Dakota Department of Health state epidemiologist, Dr. Josh Clayton, for insight into respiratory diseases and what has been affecting South Dakotans so far this season.
We have seen just a very low level of influenza. We've seen approximately 300 cases of COVID-19 each week, and we're starting to see cases of pertussis increase in the jurisdiction. We've seen a total of 170 cases so far this year, January through through the end of October. And so we're seeing kind of a mix of various respiratory infections so far this season.
Pertussis, which is known as whooping cough, is mainly found in young children and the elderly population. A large number of recent cases have been school-age kids and young adults.
Individuals who, even if they've had the pertussis-containing vaccine, especially if it's been a number of years since their last booster, are at risk of developing pertussis. The vaccine really does a good job of preventing disease shortly after it's been given, and that immunity does wane over time. But that's one of the reasons why we have pertussis spreading right now. Is it tends to spread every about 3 to 5 years, and it's been 6 years since our last large increase in the community.
Clayton explained flu season hits its peak in February, but influenza cases can spike with the holiday season. He says COVID-19 has been stable and somewhat decreasing over the past several weeks.
So far, since the beginning of the respiratory disease season in the first part of October, we've had nearly 2,000 cases of COVID-19, and that has included about 20 hospitalizations and 9 deaths. With our total influenza numbers so far, we've had 53 total cases, 3 hospitalizations, and 0 deaths so far. And with pertussis, we've had 170 cases so far, and that includes about 4% or about 6 individuals who have been hospitalized, and thankfully no deaths so far. To have the most protection possible, staying up to date with their vaccination, making sure that they're washing their hands frequently, avoiding people who may be sick, and if they themselves are sick, make sure they're covering coughs and sneezes and staying home, so that way we're not continuing to transmit or spread the infections. As individuals don't necessarily know what infection they have. And so it's important that you do your best to try and limit the spread to those in your household, friends and other folks, because you don't necessarily know what you have.
So, Sammy, what can we do to reduce the spread of viral illnesses? You talked a little bit about that. What else? What other suggestions do you have?
Yeah, besides the washing the hands, covering the mouth, I think we saw quite a drop in viral illnesses when we were wearing masks during COVID, which isn't always pleasant, but I think we found it to be pretty effective to stop, the spread of, not only COVID, but other respiratory illnesses.
Influenza. In that first year of COVID, we just saw almost no influenza at all.
And we all love to hate masks, and but necessary illness. And for us in the medical field, we've done it for a while. It's actually interesting about the time that all hit. There was an interesting piece by it was on Facebook, I'll admit, but doc that taking from animal literature and some different things, and there is something to be said for amount of viral load we're exposed to and how the disease manifests. And so, if you get little bits through a mask, you're more likely to get it, maybe attack it, and have a minor illness versus getting a full-on cough. And so there is something to be said. And obviously for those that are higher risk, they have to be a little more vigilant, or for those of us if we're around higher risks, it's probably not for everyone in the community, obviously, but the more you can do to help prevent some of that spread, it does help.
Yeah. So. I think especially those of us that are going to be in contact, think about that when you're going for Thanksgiving, for Christmas, 95-year-old grandma isn't going to be nearly as able to bounce back from her RSV or her influenza, her COVID, or even her enterovirus as the rest of us are. So think about that. Here we have a question from Facebook wanting to know about taking flaxseed every day. John.
Anything you can do. Fiber in the diet is important, and if you look at the dietary deficiencies, fiber tends to be one of those. And so if you have a great diet with fresh fruits and vegetables and a lot of whole grain type stuff, probably not a supplement you need. If there's times our diets are lacking in high fat and those type of things. It does help maybe bind up cholesterol a little bit and pass it through, so there is maybe a little bit of cholesterol lowering. It doesn't replace a statin if you have somebody with medical issues, but and if nothing else, sometimes it helps regulate the bowel movements. And so if you feel better taking it, great. It's kind of one of those personal choice ones.
Anything to add, Sammy?
I would, there are these, I don't want to call them fads because they are really great things to be eating, but they can be pretty expensive too. So like making sure that you're not, draining your wallet for these sorts of things when, you could do other things to lower cholesterol or add fiber to the diet. So just kind of weighing those benefits too.
I think the other important thing to know about flax seed is you've got to grind it because that shell, you're not going to be able to effectively grind that shell with your teeth in order to get the flaxseed oil. So you need to grind that flaxseed in a coffee grinder to make that work. So
I didn't know that. That's interesting.
Well, there you go. See, you learned something today. I always learn something on my shows. So now this is what you've learned today. Here we have a caller who's wondering about Repatha as a cholesterol medicine, and it's new, and they're kind of not sure about it. John?
Yeah, there are times where things come along that really make a big difference. In Repatha, in that class, it's called the PCSK9s. It can make a world of difference. And so it's got kind of a niche indication of sorts if somebody truly has vascular disease. So you have to have demonstrated you either have had stent, you have significant narrowing, coronary or carotid type disease or peripheral vascular disease. The mainstay is still going to be your statins for those that need them, and it's not for everyone, but if somebody is at high risk, familial history, familial cholesterolemia, the statins are where we start, but there's enough people that just do not tolerate those. And so most of us are not prescribing it for your average person. It's somebody who has demonstrated need and really needs to be aggressive with where they're getting. it does a phenomenal job. And so it is as billed, but it is a shot. It is not inexpensive, so there are some access issues with it that way. But for those that need it, it doesn't have the baggage the statins do as far as side effects, and it can make a significant difference.
So it's definitely something to consider.
Something worth considering, yeah.
Here's a question from Facebook. My child seems to be constipated a lot, and he does eat vegetables, but still seems to be routinely having issues. Suggestion, Sammy?
This is something that we see really commonly in clinic, especially when kiddos are starting some new stage in life, especially when they're going to school for the first time and they don't have access to the bathroom all the time like they might at home. So obviously you're doing the right things by trying veggies and fruits, something that has a lot of fiber in it. Sometimes what I'll say in clinic is trying a little bit of something like a Miralax or a stool softener to try it and do that daily until they have looser stools and are able to go in that way. Some kids just need a little bit of extra help in that setting.
Any other tips, John?
Hydration.
Yes.
And hydration.
Yes.
I was helping with Health Talks in Watertown this week, and the trick question is always, what color should your urine be? And it should be clear. And if it's not, you're not drinking enough. And obviously with kids, sometimes it's hard to force more fluids on them. Half-strength juice sometimes, apple juice or prune juice, if you can get them to do that, kind of helps too. So if you can do it in the diet, it's certainly the first choice, but some of those times they are just miserable, and so it's then you go to some of the medication options.
And if they're small, like younger kids too, sometimes those juices like apple juice or prune juice, if you have them full strength, can kind of help break. There's enough sugar in that helps bring water into the stool, so that's good.
But you want to minimize how much of the
certainly
the juices you're getting, because it's a lot of sugar in those. So. This is an email question. I am in perimenopause and seem to be losing more hair than before. Is this normal, John?
Well, normal is a very relative thing. So
it's a setting on your washing machine.
Yeah, absolutely. And so I don't know that I would say it's normal or the most common complaint, but certainly anything in perimenopause time frame is possible. And so I think first things first, I would visit with the doc to make sure it isn't thyroid or something else, because certainly you can get other things. And so there are multiple things that are there. And so before I just blamed it on perimenopause, I'd want to make sure there isn't something underlying it, I guess. And then it would be kind of delving into that, whether that's worth some, there's a lot of risk factors along hormone replacement therapy, but it's we're kind of learning we're back okay with it for people that need it.
It's that cycle again.
And so it is a conversation to be had with their doc.
Sammy, here's a caller who wants to know what the side effects of lisinopril are.
Lisinopril, yeah, that's one of our ACE inhibitors that brings down blood pressure. So if your blood pressure becomes too low, some people can kind of get dizzy, they can feel lightheaded, those sorts of symptoms with low blood pressure. But sometimes people can have, I'm trying to remember, the biggest one I tell people about is the cough that comes along with that. Usually dry, and it doesn't have to start right away when you start taking the medication, which can kind of fool us as doctors. I feel like patients can be on this medication for years before that cough develops. So something that is good for us to keep in mind of too.
Absolutely. Here is a caller who says they have macular degeneration. Will they eventually go completely blind? John?
I don't know the statistics on that one. I have lots of folks that have macular degeneration. It's exceedingly rare by itself to go blind from it. It depends on comorbidities as far as glaucoma, retinal disease type stuff. And so my gut reaction is that most people do not go blind because of just macular degeneration by itself, but that certainly may head that way, and certainly something you'd want to follow with an ophthalmologist that works with that regularly. But I would defer to your judgment either if you've seen something different. But
and I would say it's much the same. They lose a lot of visual acuity, so the detail is gone. It makes it hard to read, to do crafts, to do a lot of those things. But in my experience, most of them still have some vision, but it is a terrible disease, so definitely be working with your eye doctor.
Yep.
Anything to add to that, Sammy?
No, I think that.
Yeah. Here is a question from email wanting to know if there is any effective treatment for toenail fungus. Sammy.
That's a hard one to treat as well. These are really good questions. So I've heard a few different things. During, rotating with dermatology, during our medical school days, some people prescribe oral medications to try to, penetrate that nail a little bit better, because sometimes the toenails are just so thick that any type of like cream or topical solution doesn't really penetrate enough. So I've heard that works. I've heard other people that will remove the toenail itself and have it kind of grow back. So those are a few options that I know of.
Anything to add, John?
I think, similar. Yeah. And usually we'll try the oral meds, and it's trying to get under, the blood flow is the issue, and whether it's diabetes or other underlying things. And so if I've tried my usuals, then I have a low threshold to have podiatry take a peek and see if they have some other things they can try.
Yeah, I think it's also important to know that those oral medicines, even when they work, take a long time because the toenails grow very slowly. Mm-hmm. And there's an awful lot of things that cause toenails to look like they have a fungal infection besides a fungal infection. And if you're trying to treat the wrong thing, you're not going to be very effective. So, all right, I think we have time for one more question here, so I apologize to those that we're not going to get to. Here is someone who emailed in to say that they've fallen a few times and have a very tight feeling behind their knees. PT helps, but any other advice? John?
Well, I guess the first thing I would say is if we've fallen, what's to me the bigger issue is why have we fallen? And so is that related or not related? Is it because of the knee pathology or is there something else? And so make sure we're not missing something there. Knees tend to not feel great if they are swollen. And so how do you get the swelling out? So whether that's local maneuvers, whether that's maybe compression wraps, whether that's icing, whether that's anti-inflammatories, depending on if it's safe to take those or not. And then there are times when it's worth visiting. I don't necessarily typically do joint aspirations, but sometimes ortho, taking fluid off and making sure there isn't something more going on in that joint, and sometimes just taking the fluid off can be a little bit therapeutic as well. Then I'd get into looking for meniscal injuries and stuff, so your x-ray or MRI to see if there's something pathologic versus something else.
You might need an orthopedic doctor for this one. Yeah. And that pain, tightness behind the ear, behind the knees, can be a Baker's cyst, which is a sign of arthritis in that knee. So, well, this hour has gone so quickly, and thank you guys both. This has been wonderful. It's time to announce our winner for the book, and it's Sam. A book will be sent to you shortly, and we'll be after this.
On Call with the Prairie Doc has been a leading source of health education for 22 seasons. Join us this season as we continue to provide health education based on science, built on trust. Follow us on Facebook, Instagram, YouTube, and TikTok to access the entire Prairie Doc library.
Thank you so much to our guests, Dr. John McAreavey and Dr. Gervais, for volunteering their time to help us answer all of these burning medical questions. There were some great questions tonight. If you would like to see and hear more episodes of this program, please like and follow us on Facebook, Instagram, Threads, YouTube, and TikTok, or visit us at prairiedoc.org. Look for Prairie Doc Perspectives in your local newspaper and online, and listen to us on Prairie Doc Radio at South Dakota Public Broadcasting Sundays at 6 a.m. and 1 p.m. And be sure to look for the podcast of this program, Prairie Doc On Call, wherever podcasts can be found. From all of us here at On Call with the Prairie Doc, thanks for joining us for another episode of health information based on science and built on trust. Until next time, stay healthy out there, people.
Anatomical variations is a field of science that describes uncharacteristic or atypical structures in the human body. Variations are common and are typically asymptomatic. Anatomical variations. Next time on Call with the Prairie Doc.
My name is Jennifer May, and I serve on the Healing Words Foundation Board. the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful, science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Major funding for On Call with the Prairie Doc has been provided by
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions, Brookings Health System, South Dakota Academy of Family Physicians, Ophthalmology Limited, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,